Assalamu alaikum and a very warm welcome from the entire Prime Hospital and the Prime Healthcare Group in bringing this live webinar cardiology awareness program on the occasion of World Heart Day 2020. This is a great honor and pleasure for me to introduce a very well expertise and specialty of our clinicians, a very fruitful and very professional cardiology team with vast experience in treating patients. Ladies and gentlemen, thank you for joining us today on this occasion. This is an initiative started on Prime Digital, which is a new branch of Prime Healthcare Group, trying to reach through social media and all other mass communication and programs to get more closer to people and providing the logo of personalized care personally. So here we are personally taking care of you. My name is Dr. Hamad Khan. I am working in the emergency department. I'm a physician for the emergency medicine department, and I will be your moderator today for this program. Please remember that this program is recorded as well. So at any point, if you have missed some segments of this program, or at some point later in the day, or with your families and colleagues, if you would like to share, there will be a link posted which will take you through the program. Coming to the World Heart Day, it was officially started in 1999 as a day celebrated to create awareness for cardiac conditions. As you all know, approximately 15 to 20 million people every year died due to cardiac conditions. We have friends, we have family members, we know people who have suffered these losses. So in around the world, to produce to create this awareness, we have initiated in Dubai, and we are very proud to say that we are the first private hospital to do this today, reaching out to you people. I will now take you on to the panel of doctors that I have with me today. We have a combined experience of approximately 80 plus years. So this is your best chance to ask questions, or at the later point, I will be telling you how to book appointments with them, and we can take it from there. If you have any concerns or you would like to meet these doctors in person in their clinics, we will be very happy to assist you in that. Coming to the panel, I would start with my senior consultant, Dr. Sundar Kumar, who brings a very big experience of cardiology, of cardiac care. He was trained at, his fellowship was in University of South of Paris, Cardiac Institute. He's done his fellowship there. He's got vast experience. He's an MD in general medicine as well. Dr. Sundar, you are with us. Hello. Dr. Sundar.
Yeah, you can hear me?
Yes.
Yeah, definitely, everyone. So we'll take it from there.
Thank you. Thank you, Dr. Sundar. I will also now take you to the second speaker, which is, again, a very versatile cardiologist, a person who has trained a lot of residents, a lot of interns, vast experience in a government setup. There's a lot of cardiologists at the moment who would say that at some point he was a teacher to them. He's worked in private hospitals. He's worked with the government of Dubai. Dr. Ahmed Al Jabouri, welcome to the program, sir.
Ahmed, it's most welcome. It's very happy to be here addressing our people there about this very important issue.
Thank you, Dr. Ahmed. Ladies and gentlemen, last but not the least, a face not many people can miss, a person that a lot of people have known, a lot of patients and their family members have associated with him, a person who has vast experience again in interventional cardiology, Dr. Murli Krishna. He's joining us as well today. Dr. Murli Krishna, welcome to the program.
Good afternoon, everyone.
Afternoon. So, dear viewers, as you're all aware, we have now reached a point in time, especially this year, 2020 has been extremely tiring, extremely sad, extremely stressful for a lot of people globally. And that includes us, you, myself, and our family members. COVID has taken a toll on people in every aspect of their life, be it financial, social, economical, be it emotional, and that includes their health as well. Moving on with this discussion today, my first question, or the opening topic, I would like Dr. Sundar to shed some light and tell us what is the relation of COVID-19 with these cardiac patients globally and at our level in Dubai. How would you describe that, sir? Dr. Sundar? Dr. Sundar, are you with me? I think I've lost it. Dr. Sundar, my question to you is, are you with me, Dr. Sundar? Right, let's move on to the next speaker. I would put this question to Dr. Murli Krishna. Dr. Murli, would you like to shed some light on how COVID has affected the lives of so many people, healthy and unhealthy, sick and the non-sick, the cardiac patients especially? What has COVID-19 played? What kind of role has COVID-19 played on the heart, both emotionally and physically as their illnesses? How would you describe that, sir?
Yeah, yes, Dr. Hamad, COVID-19 has played a lot of games, not only to patients, but also to healthcare workers, even the families of patients, as well as healthcare workers, and even the general public. See, the issue with, and that is the reason why we are, the logo, I mean, this time the campaign for the World Heart Day is Use to Beat the Heart. We are now asking, the World Heart Federation is asking everybody to be compassionate, to be understanding, and also to be a role model for other people, so that the world becomes a better place. The COVID-19 has made all of us paranoid. Many of them have had a lot of thoughts which are all negative, but which may not be true in the first place. It is true that there is a little bit of an increased risk for people with comorbidities like pressure, heart disease, and all. If they get COVID, there is a chance that they can become a little more symptomatic than others. But then the serious cases are less than 2% of the entire people who are positive. So we should be positive in that way, that 98% of time, even if we have a COVID, it's not going to have any issues to us. So let us think in a positive way rather than in a negative way. The second issue with COVID is, the second issue with COVID is the fear factor and the implications, the emotional, the financial, the work related, and for that, of course, these kind of stressors definitely needs a lot of counseling, and there have been increase in cardiovascular symptoms like palpitations, chest discomforts, breathing difficulty, secondary to the emotional or the stress of not only COVID directly, but because of the implications of COVID. So that also has to be addressed, and definitely our department has seen a lot of patients, and we have actually tried to douse the fire by informing them that it's only a stress-induced symptoms and not more than that.
Dr. Murli, is there any specific type of chest pain that you would describe in a patient who had a history of in the past had a heart attack, and of course he comes with this typical symptom, doctor, I have heaviness in the chest. Now the word heaviness in the chest currently is so common that even in our emergency departments or around the clinics, we see a lot of patients coming to the doctor and saying, doctor, I have shortness of breath or tightness. Unfortunately, they read it they've read it in articles in Google that shortness of breath or chest tightness could be a sign of COVID. So is there any way these patients, are there any specific other red flags that we need to look at, or the patients or the family members have to watch for in order to differentiate whether this is a false alarm panic attack of COVID versus a true cardiac emergency?
See, for all practical purposes, if somebody complains of a chest discomfort, unless otherwise proved, we should give importance to them and we should think it as a cardiac symptom only. However, once they come to the emergency, as physicians, we know the red flags. I mean, we will be able to, if we take a very good history, we'll be able to point ourselves to, and of course, with other ancillary investigations, including an ECG and a blood test, we'll be able to gauge what exactly is happening and inform them accordingly. But if, unless otherwise proved, if the symptoms are significant, it's better that they come to the emergency and clear things up.
Great. Dr. Ahmed, my question to you is very. It is a debate. It is a blame game. Men saying women have a lot of cardiac conditions. Women saying that men are at high risk. But what is your take on this gender differences? What do you think? Is there any specific gender at a higher risk of cardiac conditions? And if so, could you tell us, is there any specific reason for that?
Yeah, there is usually a general idea in the society that men are having higher incidence of ischemic heart disease, or what we have to define it more in a general way, like atherosclerosis problem compared to the women. There has been long time studies about this difference and the protective, the disputed protective effect of the female hormones, and in explaining the differences. And even, in the late 80s, there was an attempt to give such hormones for postmenopausal women and trying to possibly maintain this difference in the incidence of ischemic heart disease. But all these studies and trials actually has failed to demonstrate a major benefit. So we have to admit that, the total number of the male patients in our clinics and our practice is higher than the females, that's for sure. And we know that probably hormonal body structure, anything may make them less. But you have to know that in heart disease, this issue could be very tricky. Now, I will give you just a simple example. One simple story could tell you the difference. At one time I received a call like 2 a.m. about a small young lady, Asian. She has no risk factor, no diabetes, no hypertension, no lipid, nothing at all. She had the chest pain. Now, even the junior doctors were not convinced that it's a major thing. And it's 1 o'clock in the morning. And I always have this impression that anybody coming with the chest pain after midnight to the emergency, it is serious. So we decided to admit her and follow up. She reached the CCU2 at 4 a.m. I was called to take her to cath lab when I found that's a very nasty, complex lesion. So, and it was, small stature, and we did a very big artery with 2 stents. The question that there may be a difference, but that should never be, an excuse is not to take care about them. We do have cases, and the cases are really very risky, very serious. That lady, even during the COVID, she herself, she didn't believe that she had a major issue, a life-threatening issue. Thanks God, we are able to save her life. But then during the COVID, she stopped medication. After the COVID, she come back, no medication. And simply when I show her the angio, the procedure and the things, and I begged her, and literally I begged her to not stop the medication. Yes, we have to admit there is difference, but the seriousness of the situation should not let us be directed away from the possibility that a major heart attack could occur. It is occurring, and sudden cardiac death is there. So I think we should always be careful about that.
Thank you. Yes, I agree with you. Heart should be taken very seriously. It is indeed the vital organ. Aristotle in the 4th century BC said that I identify the human heart as the most important structure of the human body. Until date, we all believe in it. Moving forward, Dr. Sundar, can you hear me? Are you with us now?
Yeah.
is veg.
Yeah.
Right, Dr. Sundar, moving this forward, my question to you, you have been in the West and you've been in this part of the world. Uh, I have associates and friends, and we all do, and we all hear that the heart conditions primarily arise in the Western society or the Western countries uh, after a certain age. You can say late middle age or old age. Compared to Dubai or this region or this part of the world, there's a major gap in the age differences. We see a lot of young patients, uh, a lot of young people with heart conditions taking a lot of chronic cardiac medications or even having high blood pressure. What is your take, Dr. Sundar? What do you think? What is so different here? And if there is a difference, what is your advice to our people on minimizing this damage to the heart? What would you say on that?
Yeah, there are two issues about it. Naturally, if you look at some group of race, for example, the South Asians, naturally the disease is seen at a much younger age than what you see in the Western population. So there is some amount of genetic predisposition for this. So which, for example, the population here, we have a huge expat population, we have a huge South Asian population. So naturally, the genetic predisposition for this is a huge factor. The second factor, what is also an important issue, is the smoking. Now, smoking is one of the major causes for cardiac illness in young age. So if you look at the people who develop these problems at young age, there is a huge amount of people who are into the habit of smoking. So that is the second important issue. And of course, the other lifestyle issues of lack of discipline in terms of physical activity, lack of discipline in terms of the food habits. So all these three contributes to the development of disease at a younger age, rather than what you see in the West, where they are a little more disciplined and the genetic predisposition also is a little less.
Great, thank you. So of course, diet makes a big role. Again, a lot of people here, those who are away from families, they do not have access to home cooked meals or fresh food. So a lot of the food is stored. A lot of food's easy to cook, easy to make. Could be one of the factors. Dr. Murli, my question to you: is there any clear evidence of a certain diet in this region which has led to these illnesses? For instance, salt intake. What is your opinion? How is salt related to high blood pressure or leading to heart conditions? Because without salt, I mean, people are very fond of salt. So a lot of external salt on food, on salads, is the main part of the food. Is there any role between salt and high blood pressure or heart conditions?
Yeah, okay. The first part of the question is you have already answered it, because majority of our population here, the expat population, depend on outside food, the hotel food. So naturally, they may not be able to control their diet in the way it should be controlled. Regarding the salt, yes, hotel salt is definitely related to high blood pressure. If you have more salty food, definitely it's proven beyond doubt that it can in the long run affect your blood pressure, and it can affect the stiffness of the arteries, and it can definitely cause high blood pressure and later on a stroke or a cardiovascular event. So there's no doubt about that controlling the salt will definitely help us. And regarding the other diets, as already mentioned, we have to rely on, we have to definitely talk about low-fat diet with a lot of fruits and vegetables included in the diet. And of course, less of oil, including fried food items.
Right. This is Dr. Murli. This is just personal interest. I have a lot of arguments, I can say, with a group of circle of my friends. They are on strict vegetarian diets. Now, for a layman, people who are vegetarians, I've seen a lot of vegetarians as well having cardiac conditions and high blood pressure. So, is it necessary that if you are on a pure vegetarian diet, that your risk of getting heart conditions would be less?
No, never. There is nothing like that. Just because you are a vegetarian diet, it doesn't mean that you are free from cardiac illness, because even in vegetarian diet, it can be very oil rich, very salt rich. So there is no relation. The only thing is that, in fact, if you are a non-vegetarian, fish is actually good for you because it contains a lot of omega-3 fish, but not fried fish, of course. Fish is good for you. Only the red meat you have to be a little careful of. Otherwise, fish is actually good for the heart. So it doesn't mean that vegetarian diet is protective, never. Because as you rightly said, there are enough and more vegetarians coming with obesity and with all the risk factors and going in for a cardiac or a ailment or a stroke.
Great. Talking about food, Dr. Ahmed, my question here would be caffeine intake. Again, culturally, socially, we have a high intake of caffeine in this part of the world. Of course, in the Western world as well. But here, coffee is a tea, especially tea, is more of a habit. 2 to 3 cups a day. Is there any role of high caffeine intake on these patients with heart conditions or blood pressure? Because I've seen a lot of patients, a lot of people, they habitually take 2 to 3 cups of coffee or tea every day. Now, is there any advice for such patients or such people?
It's a very interesting question. Actually, we are facing similar question or this question on daily practice. I think the most important thing now is that we have to be, very sincere and very accurate to the patient. The patients are no more, we are their own source of information. There are social media, everything and information. So it's better that we should be very much strict about our condition, because you can take any piece of information and then suddenly in the media, the newspaper or online, somebody can give another. Now, until now, for the caffeine, we don't have really a very solid evidence that it's harmful. Yes, there are even on the other end of the spectrum, there are evidence, somebody will say that they're good. But in general, caffeine, it's very well known that it has an arrhythmogenic effect. It can cause ectopics and tachycardia and palpitation. It can really a little bit push up the blood pressure. But we have to be honest, there is no definite, study approved some relation between the caffeine and the hypertension. And there is, on the other way, as I told you, many reports on the media, they are praising the coffee for presumed protective effect on the heart, something else. So in general, we always advise our patient for moderation. Moderation is the key point. Okay, take 1 cup, maximum 2 cups per day, don't exceed that, and avoid the caffeine which is available now in other sources, The energy drinks, we have really very harmful, which having a very huge level of caffeine. So when we have to be honest with the patient, now even go with the diet, you will see some reports. Okay, animal fat is bad, fish is good, but still, no definite explanation for that. What we have, saturated fat is bad, and polyunsaturated fat probably better. So we have to be on moderation. So we just advise our patient not to take too much coffee, avoid coffee on an empty stomach, avoid coffee in the morning, try to not use animal fat as you can, take the lean meat, and that will be, I think, moderation is the key point.
Absolutely. Moderation in every aspect is important for life. Dr. Sundar, my question to you, another, you can call it a myth, you can call it reality right now, but I have seen people with one reading of high blood pressure. When I say high blood pressure, they will come and they will say, doctor, I checked my blood pressure at home. It was 150/90, and I'm hypertensive and I need medications. Dr. Sundar, what is your take on genuine classification or identification or diagnosis of patients with blood pressure? Is every high blood pressure condition called hypertension?
No, you don't diagnose hypertension based on a single recording. So naturally, when a person comes with a single recording, which is high, from what you're saying, it looks even to be the mild high, you don't straight away start medications. So you need to assess these patients, look into all aspects in terms of one, whether they do have any other effects which hypertension can cause on the body. For example, whether they have any hypertensive effect seen on the eyes, whether they have any hypertensive effect seen on the heart in terms of ECG variation, echocardiographic variation. So you look into all these things and then you decide whether this is just a single high or whether this patient has had a hypertension and has had some effects based on that on the body, and then you decide on the treatment. And also, we also often use what we call it as an ambulatory BP monitoring. Whenever there is, fluctuations between normal and slightly high, such values do come often. So then what we do is we put them on a 24 hours monitoring with an ambulatory BP monitoring. So that would give a full spectrum of the blood pressure values during the daytime, during the nighttime. So that helps us a lot to decide how the blood pressure is behaving, because you also see often patients who will just walk into the hospital and that time the pressure goes up, what we call it as a white coat hypertension. And when they go out of the scene, the blood pressure becomes normal. And these patients, it's a little challenge, but when you put them on these ambulatory BP monitorings, you know very clearly how their BP profile behaves. So basically, you don't start treatment with a single value. You need to be assessed by the doctor. You need some investigations, basic investigations, and then you decide whether really the patients need medications.
Right. Dr. Sundar, again with you. For a layman with high blood pressure or cardiac disease, I have heard numerous times the doctor telling him that you need to exercise. Now, for a layman, if you have a high blood pressure and you exercise, are you not increasing your blood pressure more? Like, does that not increase the risk of any events leading to some conditions which might get worsened by this exercise? How does exercise actually help with prevention of cardiac conditions?
No, exercise has two aspects to it. One is the control of the risk factors, like helping for the diabetic control, lipid control, and hypertension control. Here, you specifically asked about the hypertension. Now, you don't ask a patient with a BP of 190 or 180 straight away go and do an exercise. We don't advise like that. For example, if a patient is initiated on medicines for hypertension and it is under reasonable control, then with exercise, it helps you to reduce the dose of the medication. It helps you to bring under control much easier. And also, if the blood pressure is only on the mild high range, let's say it's around 140 to 145 and 150, and you're looking at lifestyle modification as a form of treatment for these hypertensive patients, again, doing an exercise would not bring a big harm to these patients. So you need to clearly define the patient first, how his blood pressure is, whether it's mild or very high. And if it's a very high, you don't say that go do an exercise or something. You like the blood pressure to be a little bit under control before you advise them, so that it helps them to have good control as well as for reduction of the medication dose.
Perfect. Thank you. Thank you so much for the insight. Dr. Murli, coming to you. Again, I consider myself right now to be one of the laymen. So I will be ignorant when I ask you these questions. Patient walks into you, or I receive a call, or a person tells you that, doctor, I have some burning in my chest. Most of these patients, most of the people complain of heartburn, or they say that I've been burping and belching. I was feeling uneasy on my chest. Dr. Murli, in your experience, and for general people, for the population, for us, how important is this symptom of heartburn or belching or this feeling of nausea, which could be because of a previous gastritis? How close is that related to a true cardiac event? Because a lot of times patients actually don't come to you because they say I felt a bit gassy, I burped, I threw up, and I feel better. Is there anything important that we need to note about this clinical feature?
See, the symptom, what we have described now, the belching, the burping, and that definitely is primarily a symptom of gastritis. However, it is also a very deceptive symptom, because many of our cardiac patients, the pain is perceived like a vague discomfort in the epigastrium that is just below the chest, especially if it's the inferior olemite. That is, if it affects the the below portion of the heart. It can manifest as a typical belching, burning symptom. So if the belching, burning persists in spite of the usual home remedies like, taking some soda or putting the Eno or whatever it is, and if still persists and if it is associated with other symptoms like sweating or discomfort other than in the stomach, discomfort happening in the throat or in the arm or in the chest with sweating and all that, or if the discomfort persists, it has to be considered as a warning sign, and especially if a person has other risk factors like diabetes. Many times diabetes does not cause any chest pain, so if a person has vague symptoms, so a diabetic or a long-standing diabetic or people with other risk factors, smokers, all of them have to be worried about a symptom if it persists, especially the belching and the burning.
Thank you. Dr. Ahmed Jabouri, question for you. How important is how often, let me put it this way, is a person who crosses 40 years old, I will keep 40 as a benchmark here. So post 40 years old, how important is it to see a cardiologist? Because a lot of people, this is psychologically to accept that I have to see my cardiologist sounds a little alarming. They start feeling that they have actually been sick with some heart disease. So in your opinion, what is your advice to people when they touch 40 with risk factors? How often should they come and see you? And what is the necessities that need to be done as a follow-up care with cardiology?
Look, this is quite an interesting issue. There are many countries and many healthcare authorities in many countries. They have set up a preventive protocol. Starting at the age of 40 and sometimes a younger age, 35. It does not primarily involve the heart, but it involves the heart, like scanning for colonic carcinoma, scanning for breast carcinoma, and like what we call it, oncology parameters. I think it's vitally important that the person is more engaged in his preventive aspect. I think it's a vitally important issue. He should be more engaged people in the preventive aspect of medicine. Specifically those people who have a sinister family history of ischemic heart disease, sinister family history of malignancy. It's very important that they should be engaged, and we have here in this hospital, we have developed a very well-established program, what we call it wellness program. I think it's vitally important that we do this health checkup. It's not necessary to go for a cardiologist, but you can even go to the GP and you establish this basics of the wellness program. I think if we could tackle, like hypercholesteremia at young age and treat that, it could really be very helpful. We could tackle also like sugar, pressure, everything. The preventive protocols are now getting more popular everywhere in the world. We are here since the beginning of the hospital has established a protocol. I think people should be actively involved. You could listen like some people go on the other extreme. Okay, everybody above 40 should take aspirin. That's not really true. That's not really true. I think taking the opinion of a medical people, not necessarily cardiology, go to the GP, go to the internal medicine, but a screening preventive protocol is vitally important for the people who are above 40. And even in our country, in our region, in our population, I think anybody above 35 should be actively involved in a preventive protocol.
Absolutely. You're right. I think awareness is more important at this point. Once awareness kicks in, the society becomes more careful, and that carefulness leads to control on conditions. Dr. Sundar, what is your take on cardiac arrest and COVID? Because a lot of people contacted me. They walk into the hospital. Their questions are cardiac. Why is there a cardiac arrest? What is the relation of COVID-19 with cardiac arrest? Is it preventable? If it is, what is your take? What kind of medications should be started? Now, I will elaborate more about aspirin. There is school of thought. There is different types of clinicians. Some of them they prefer to give aspirin to every patient with COVID. So COVID and cardiac arrest, is there any relation between them?
No. See, actually, COVID affects the heart in a subgroup of patients. Now, COVID, most often, as you know, it affects the lungs, and in a subgroup of patients, heart is also involved. What really happens is that the COVID causes inflammation, infection in the heart, what we call it as myopericarditis, and which can cause the weakening of the heart muscles function, and therefore it can lead to cardiac arrest, like what you're saying. In a very small subgroup of patients, it can affect the heart without affecting the lungs. But I don't think there's any role for preventive aspect taking aspirin for everyone to prevent a cardiac involvement in a COVID patient. So if there is any suspicion of COVID, you are going to get evaluation done for that. You're going to get treatment for that. And cardiac assessment will come as a part of it, both in terms of clinical assessment and if necessary, an ECG or echo, if necessary, if there is suspicion more towards the heart, would be done. But otherwise, I don't think it's needs to be taken any medication as a preventive stuff. I don't think there's any role.
Great. Dr. Murli, cardiac patients and cardiology consultations. What would be your advice to patients? A lot of people are skeptical these days coming for their follow-ups. The moment they hear that we need to go back to the cardiologist to check ourselves, there is always a fear of COVID. There's a lot of fear that we have to go and expose ourselves. In your experience and based on your clinical practice these days, if a patient had some sort of heart condition and he had to come to you, how safe is it to approach a cardiologist, and how safe are the cardiology procedures, the angiographies these days in the COVID era?
Even in the COVID era, our hospital has taken all the necessary precautions, and there are systems in place wherein none of us, either we as healthcare workers or the patients who come and see us, nobody is in any way at an increased risk or at an increased exposure risk for COVID. Definitely, we are COVID-free as well. See, coming to the hospital, if there is a necessity, is definitely welcomed, because in the end, we should not go into a unwanted situation just because we do not want to come to the hospital or the clinic. I would say that, if there is a necessity, yes, definitely we should visit the doctor.
Absolutely. Dr. Ahmed Jabouri, what is the role of a CT coronary angiogram in identification of cardiac conditions? What is your take on CT angiogram and cardiology?
Well, look, the introduction of the CT angiogram, usually, it has become very popular after the improvement in the CT, machine modification, upgrading, ability to get like 64 cuts, 126 cuts. So the CT actually, it has got some role. We have to admit that. Because we have a lot of people are actually coming who have, low risk. It means that a person who is, around below 40, he has no diabetes, not a smoker, he had the chest pain, gone to treadmill test, the specificity of the treadmill test is fair, but it's not 100%. So a lot of these people, in the past, we are stuck. We are exposing them to maybe unnecessary invasive procedure. Like I have been doing this NGO for 30 years. I have seen almost all complication, specifically in the old days where the contrast was actually an old contrast with higher risk of allergy, high risk of reaction. So nowadays, this group of people who doesn't want to lose their job working, he doesn't want to, get sick absence, he's not interested in exposure to an invasive procedures or arterial puncture or tubes inserted in his heart. I think this group of people, the CT angio, it actually is a good alternative. but you should spend some time explaining to the patient. You just cannot send the patient to the CT angio. CT angio are usually people who are, low risk, people who have the symptoms which not classical, the people who have non-diagnostic treadmill test, the people who are actually could have, benefit from avoiding an invasive procedure. They should know that this machine has its own limitation. They should know that this machine is still using the same contrast. We should protect the kidney, all this stuff. So, despite all this, I think the key point is to spend some time talking to the patient, explaining him, and still it has some very important role now. We are doing a lot of these tests nowadays, and it has been very convenient to the patient, very helpful. I think we should continue with that.
Absolutely. We are doing it at Prime and we've been doing it as a routine. And it's also helping us in early diagnosis. Thank you. Thank you. Dr. Sundar, my question to you is young athletes, while they are playing in the soccer field or playing cricket, suddenly they collapse and they are pronounced dead. And unfortunately, these are young adults and they're healthy and they're athletic. So they are physically very healthy. What is your take on these sudden cardiac deaths in healthy population, which are young? And what is your advice to the young athletes and the young population? The idea of mine is he's old, he has cardiac conditions, he had a heart attack. But this is the group of people I'm talking about, which are the young, healthy ones. And most of the time they collapse while they are playing. What was your advice to them? How can they go and get this thing checked? What is going on with their hearts and what is the checkup that they need at this point to identify these conditions?
See, the sudden cardiac death in athletes basically happens due to 2-3 conditions. One is if they have some abnormality in the electrical current conductions in the heart. For example, they may have some electrical variations in the heart where the heart suddenly goes off very high, fast, what we call it as tachyarrhythmias, and it can cause cardiac arrest. So that is one group. Second is in some patients, they can have abnormal heart muscles where it's significantly thickened for no reason, what we call it as hypertrophic cardiomyopathy. So again, these subgroups of patients can have a high risk of sudden cardiac death, especially with athletic activities. And very rarely we can have some abnormalities with the coronary artery course, where they go between the aorta and pulmonary artery. And these subgroup of patients also can have cardiac arrest secondary to exercise. So these are some of the conditions which can produce sudden cardiac death in athletes. Now, should we screen all athletes and screen them before we send them for athletic activity? Now, this is a question which is not fully answered because in some countries, especially if you take up the big clubs and football clubs, they have a full screening program to detect or to evaluate for these abnormalities in the heart. For example, they would do an ECG, they would do an echocardiogram, which will show this abnormal heart muscle thickness presence or not, and also some group who even does a stress test. So some clubs have an evaluation to an extent to see if there is any problem in the heart, which I earlier discussed, is detected or not. But this cannot be implemented on a full government basis for everyone whoever does an athletic activity. So the recommendation whether you should have an evaluation or not, it depends on where you are taking part in the sports.
Are there any early signs to identify this? Let's say I was playing football the other day and I developed some shortness of breath. I know it could be a normal variant. Is there any telltale sign? Is there any specific red flag that the young population need to be careful about?
No, as you said, if you find any discomfort during your activity level, definitely it needs a medical evaluation. There's no doubt about it. So if you have any discomfort, definitely it needs a part of cardiac evaluation with an electrocardiogram, an echocardiogram, and if plus minus a stress test based on the initial assessments. So if you have discomfort, definitely. But whether you will screen every person who's doing athletic activity with the cardiac screening, then that depends on where and which level of activity you are subjecting yourself to.
Is there any research on taking a group of population, young ones, and doing a study, or is there any research, any numbers in any part of the world, even including the West, that they have taken a group of young population and randomly screened them with echocardiographs to see the size of their heart?
Yes, there have been studies where they have picked up all the school children who are subjected to athletic activity and see whether we can pick up any abnormalities in the ECG and echo. But this did not turn to be a cost-effective measure. So that is why they are not advising every person in the school who is subjecting to an athletic activity go and do an ECG echo. So this is not a general recommendation because it's not cost-effective. Because this is going to happen 1 in 1,000 person or 1 in 10,000 person. So you're not going to do everyone a screening for all these things. So as I said, if you're going to be in an atmosphere where you're going to be in a athletic activity which will need a very strenuous activity, and those are the groups where maybe you will go up and do a cardiac screening assessment.
So one cardiac screen or one electrocardiograph with one echocardiograph of the heart. Will it suffice to rule out and to identify these patients early? For example, if coming down the lane with the help of the management and the Prime initiative, like Prime Healthcare Group has done a lot of initiatives, and they've always been in the light with doing things for the first time. Possibly at some point, if Prime decided to go and pick up a group of population, do you see yourself being a part of that? Would you advise? Would you be an advocate of this study?
See, that's what I said. As you said, even if you do an ECG and echocardiogram, you will probably identify a small subset of patients who are at risk during the athletic activity. But if you ask me whether by doing this test 100% can you stop a sudden cardiac death on the field, I would say no, because there is a limit through which your screening can be done.
Of course, absolutely. Well said. Dr. Murli, there are two roommates talking to each other, and one of them suddenly collapses, complete collapse. What do you advise? What is a layman, a common man? What is his approach to a patient, a bystander, who witnesses someone who goes into a state of unconsciousness?
Yeah, of course. The first thing will be the basics of BLS, which is you should assess scene. You should check the response. If there is a third person, you should ask them to call for help. Otherwise, if there is no help available, you should try to do the help and start the basic resuscitation, which includes the breathing, the airway management by and the CPR. That's what I would say. I'm not hearing.
Yeah, can you hear me now?
Yeah, now it's clear.
For a layman, is it advised from a cardiologist's point of view to approach and start chest compressions?
I mean, it is always better that everybody, there was a program in my hometown where I come from, in India, where every week they were training at least 100 people for BLS, basic life support, and that included initially all the auto rickshaw and the taxi drivers and all the laymen, and that program is ongoing. They were teaching everybody the basic life support. So in the end, yes, that helps.
So we should initiate this. Again, we will request our management, and Prime Healthcare Group has always been to provide awareness and to create such programs. So yeah, we do look forward to this. I think it would help a layman to understand the concept of early compressions can be life-saving, as long as he doesn't do any other techniques, just to teach him just how to compress on the chest until help arrives. And usually in Dubai, the help is arrived within 8 to 10 minutes, or sometimes even faster.
Yes. We have the option of calling the 911. Yeah, that's
absolutely, or in Dubai 998. Right. Moving forward, again, the ones who have joined us at this point, we are having our first cardiology webinar, the first of its kind in UAE right now. We are live on all platforms. if you have any questions or concerns, and if you have any doubts regarding your conditions, we have our panel of experts, Dr. Sundar Kumar, Dr. Ahmed Jabouri, and Dr. Murli Krishna, very, very experienced cardiologists, combined 80 plus years of experience amongst them. They lead a very, very fine cardiology team. They are available at Prime Hospital in their outpatient clinics. You can always book appointments with them through the operator, and they will be very happy to assist you in your cardiac conditions and otherwise maintaining your blood pressures and other cardiac conditions. Now I would now move to some of the questions that were sent by our viewers. So I would, as I go, I will request the panels to answer the questions. My first question is, should one start taking aspirin as a precaution after the age of 50? So, Dr. Jabouri, does every patient, once you reach 50, is it a rule of thumb now that I start aspirin?
That's a very interesting question, and it's actually this question. It has been the concern of the medical community for 10 years. There was an issue raised earlier. Why should we keep aspirin as over-the-counter medication? So in general, there are many studies which have been carried out in the United States and Japan and everything. Now, what the conclusion of the FDA is actually, which was been published like 7 years ago, they said that it's very clear now. For a primary prevention, what I mean by primary is somebody who doesn't have coronary artery disease, ischemic brain disease, stroke, or leg disease. These people with primary prevention, it was all the literature about aspirin benefit has been reviewed. They came across a conclusion which I find it very interesting. They say that there may be evidence that the aspirin can reduce the colonic carcinoma by almost 25 to 30%, but its benefit as a primary prevention, preventing heart attack, is really doubtful. So in general, there is a critical balance between the benefit harm. We all know that aspirin can use to a life-threatening bleeding. So in general, there should be a careful risk estimation, and any person who have multiple risk factors of coronary artery disease, it would be a very good idea to start aspirin.
Absolutely.
Strong family history of heart attack or stroke at younger age, less than 45 in males, diabetes, hypertension, smokers, hypercholesterolemia. So any couple of these risk factors, I think it will be a very good idea to start. And now even you can go online. There is what they call it aspirin guide, aspirin calculator. They tend to be a protocol that ask you about like 10 to 15 questions, and then it could give an idea whether aspirin is good or is not indicated. It's still on the system, on the app stores, aspirin guide, aspirin protocol, a guide published by the American College of Cardiology, something by other authorities. I think it's a very good idea to go through that, and possibly you could also have an understanding of the possible risk associated to aspirin. I think it's a very good idea to go through these apps and also to limit the use of aspirin for people who have no stomach problem, no peptic ulcer, no previous gastric bleeding, no bleeding tendency, no bleeding risk, multiple significant risk factor of coronary artery or ischemic stroke. These people are really a very good candidate for aspirin.
Absolutely. We would actually request these patients to come to the cardiologists, to you guys, and to give them this advice, because there's a lot of hidden information. As you said about aspirin, it causes a lot of gastritis. We see a lot of patients coming with abdominal pain. So in the long run, they can actually cause more harm rather than first consulting you.
The gastritis is not a problem, but you have to know that there is a fatal bleeding. Although uncommon, it has been reported with aspirin. So
Absolutely.
that's the touch point about the issue. So the selection of the patient is vitally important. I don't think anybody could make his own decision and go on to use aspirin without taking a solid or some opinion.
we just hope that this is why we have you experts. So we would actually suggest and we would advise them to come to you and take appointments and get this information from you. I will move to the next question. One of the other viewers have asked us, I had my bypass surgery last year in India. What sort of post-surgery care is required? Lifestyle modifications? How frequent should I consult with my cardiologist? And what are the follow-up tests that I will need? My question for Dr. Murli, what do you suggest?
Yeah, see, this gentleman who has had a cardiac bypass most probably will also have other comorbidities. So he has to take care of, I mean, if he has diabetes, he has to take care of the control of diabetes. He has to keep the HbA1c under control. He has to keep the LDL cholesterol level below 55 now, according to the recent guidelines. So for that, he needs definite monitoring, at least a blood test once in 6 months, and to assess what is his status of all the risk factor control, how well it is going. And of course, it would be advisable for him to have a consultation with a cardiologist once in 6 months for these blood tests and also a general checkup, including the blood pressure. And once a year, there is no harm in doing a full evaluation, including a stress test, to know how well his grafts are functioning and how healthy and how fit he is.
Very well. Very well. That was a very nice answer. I hope we've answered the question to the gentleman. I have another question here. Dr. Sundar, the question is for you. I have an issue with my heart pulses. I did check up 3 times, but the results are all normal. I want to know what I have and why is this happening to me and how can I control this? So I think the patient is trying to tell us that he feels that his heart is beating fast, palpitations.
Yeah, but so I think the question is that he has some irregularity. He feels some irregularity with the pulse, but then whenever he checks, he feels the pulse is normal. I think the check is by himself. So I don't know how good is or how reliable is his own examination of the pulse. So that is one thing. So what would be good is if he has any doubts on any variation in the pulse that he sees, whether it's irregularity or the rate at which the pulse goes on. Nothing wrong in taking one medical assessment, meet a doctor, just get a basic assessment from him, and probably ECG done would sort out things well for him. So I think he should see a doctor and sort it out rather than to sorting it by himself.
Great. Of course. I would request this gentleman or the lady who has posted this question to have a word with our cardiologist, because at times this pulse going high, again, a normal pulse, you should not feel your pulse normally. I don't feel it, nobody feels it. If you start feeling it, there has to be a reason. So it is time for you to get a check with our cardiologist at Prime Hospital. Dr. Jabouri, moving to you. The next question is for you. What is more accurate to follow? What your mind says and what your heart says. And there is a saying that the heart has a mind of its own.
Yeah, it's a very nice question. It's depending about, what is the topic. Now, if it's romance, I will definitely advise to go with the heart. But if it's a medical issue, I totally advise the mind,
Absolutely.
Yeah.
Absolutely. I believe this was the answer.
Unless it's romance, I tell them I will totally vote for the heart. But now with this issue, if it's a medical issue, I think the mind will be the more reliable source.
I have another question. Dr. Murli, this is for you. They say I have a gut feeling. I feel from my gut. I feel my gut feeling or something else is telling me. Do you think there is more than 2 hearts in the body? And do they actually, this is just a lighter note. So is there more than 1 heart in the body which controls your emotions, Dr. Murli?
See, I think in the end, it's the mind which controls our emotions. All the emotions come from, we feel the emotions mainly in our torso, in our chest and the upper abdomen. So maybe that's why we think that the heart decides on our emotions, and the gut feeling, that word must have come from the feeling what we get.
Absolutely.
Even when we are happy. Yeah. But even when it's the mind which
Yes. What a beautiful answer. Yes, Dr. Murli, question for you now on a serious note. What is the best procedure we can make to cure the dropped beats?
See, just because we have a drop beat, I don't think we should be worried about it.
What is a drop beat, Dr. Murli? In a layman's term,
it is actually not a drop. It is actually an extra beat. And the extra beat resets our natural heart rhythm. And when it resets, it pauses for a moment, and then again the own rhythm takes over. So that pause is felt as a drop beat, but in effect, it is an extra beat actually. I hope I am clear.
A drop beat, is it a drop beat in a young patient and a drop beat in the old patient? Is there anyone which is more alarming?
Not necessarily. Of course, if it's in an older person with other risk factors, it's more alarming. But in a younger person, if otherwise healthy, it's fine. But if it's a very frequent phenomenon, yes, then you come for an evaluation, and we have certain tests like the Holter monitoring and the echo and all that, which will tell us what exactly is happening. And if it's just a drop beat in this, see, drop beat is a colloquial term. Actually, the beat is reset, and actually the extra beat resets the heart, and we feel it as if it's a drop beat, but actually it's an extra beat.
Absolutely. I'll move to the comments now as we're moving towards the end of the program. We have some of our viewers who have sent some comments, and they are now posted live on the page. Nitya Raj, Mr. Nitya Raj says, hi, please find below query last month. I took ECG in that. There is some abnormal changes, as my GP said. They referred me to the cardiologist and advised me to take the TMT and echo test. My TMT is normal, and my doctor advised me to do some exercises regularly, 20 minutes. What kind of exercise do I need to do? Dr. Sundar, the question is for you. So what is the type of exercise? Can you also elaborate based on COVID now? A lot of people are scared or skeptical to go out of the house. Is there any specific set of exercises which are simple, basic, yet they can be done indoor in the house and can be more efficient on the heart?
No, in general, just leaving I'll come to the COVID later. In general, for the exercise part of it, as far as the heart is concerned, what we advise is at least 30 minutes of walking every day. And what the majority of the recommendation goes, it should be at least 150 minutes per week. That is about, at least 30 minutes on 5 days a week or something. That makes it to around 150 to 160 minutes per week. And also, they also recommend at least 2 to 3 days a week physical exercise and the stretch exercises for the joints and abdomen and involving all the joints of the body. So this is a general advice. You don't need, if you're doing a vigorous exercise, like for example, running, it may be enough to do at least 20 minutes a day. But if you're doing a moderate exercise like walking, at least 30 minutes to 35 minutes per day. This is what is the general recommendation. Now, as far as COVID situation is concerned, you can do the same thing in the home with all the stretch exercises. And also you can combine with yoga, which will really help you as far as the breathing aspect of it, which also will add up with the efficiency of the exercise.
Very, very, very interesting. Sure. Another Facebook user says too many research is coming nowadays regarding the sodium, which will not affect our blood pressure. Can you give some more clarification regarding that? How does it increase the blood pressure? Dr. Ahmed Jabouri. So the person here has said that there is a lot of research that sodium does not affect the blood pressure. So now he wants to know how does sodium reflect on the heart? How does it relate to the heart?
Yeah, look, it's actually, we cannot depend on the researchers. I totally agree. There are many papers, opinions. Even now, somebody will go in the media and said, okay, cholesterol is not harmful, it's good. We are facing this issue. There is no doubt that excess sodium can be harmful. We don't say sodium is bad. We say excess sodium is bad. Let's know about the dietary protocols. In our country, the cooked food, the bread, has an amount of sodium is more than we need actually. I don't advise the people to go for the salt-free diet, specifically in our region with the hot weather. So it's a moderation again. Now, how is the sodium affect the blood pressure? You have to know that the kidney, it has a major role in establishing the blood pressure. There is a specific system in the kidney arteries which is going to sense whether there is the sodium is low or the sodium is high, or it's going to sense where the flow in the kidney is high or the pressure is low, depending on that sensor in the kidney. Now, this will adjust, the blood pressure. And that's why there were trials like 5 years ago, and there is an established treatment to control the blood pressure. It's still going on in Australia. In the United States, they have stopped it. They find that it's not so much useful. They go to the renal artery, they cauterize that area and that sensor, and they claim they have improved the pressure control. So it's actually the sodium content in the blood will be sensed by a specific sensor in the kidney, and that sensor in turn will trigger some hormones, some nerve regulation in an attempting to increase the blood pressure. So actually, sometimes in some people, that sensor, like anywhere else in the body, any sensor, it can just malfunction and it will lead to exaggerated pressure. That was the theory well established. Again, some people try to use, and it was done here in Emirates, in Sharjah and Dubai, and then it was studied in the States, multiple studies, and they decided that it's not useful to control the pressure. But it's worth to be mentioned that it's still practiced in Australia. So this is the link. So the sodium content with the what we call it, let's name it really into the pressure control center in the kidney. Okay, it's a very complex system. It's consisting of arterioles, venules, hormones, aldosterone, renin, and all this system will act according to the sodium control to sodium content to control the blood pressure. So this is the major link between the sodium and the pressure. When this system gets malfunction, the pressure will go higher up. In addition to that, always sodium will take water in and increasing the volume.
Right.
And please be about the literature, because not all of them are really sound.
Absolutely. Thank you for this explanation. Dr. Murthy, one last thing for you. Black chocolate, which is dark chocolate and milk chocolate, myth or reality? Dark is better than milk chocolate, and the effect of chocolate on heart.
No, dark chocolate definitely has a lot of antioxidants, and definitely if the sugar content will be much less than milk chocolate. Milk chocolate will have more sugar and more fat. Chocolate has a lot of, so definitely it is the better option. But as Dr. Jabouri has already mentioned, everything is in moderation.
Absolutely. Dr. Sundar, would you like to add anything to those questions?
Sorry, I just lost the link a little bit. You're talking about, sorry.
We were talking about sodium, salt intake, and we were talking about chocolate.
I think what Dr. Jabouri explained is very good. I mean, in the sense of what we look at is we want to avoid the excess salt usage. That is what we are looking at. What is normally present in the cooking is absolutely accepted. So what we are looking at is excess salt, like what you're using is high salt, things like chips and stuffs like adding salt for buttermilk. Those are the things we like to totally cut off. So if you're taking whatever is the normal salt in the cooking, I think that's fine.
Great. Coming up, next one is when to use teleconsultation option in a vague chest pain. Dr. Sundar, chest pain is a very vague symptom and a complaint. Chest pain could be from so many reasons. In your experience, right now, a lot of patients, again, they're very skeptical in going out with the risk factors. They're more scared to go out. Which ones would you say fall in the category that could come for a teleconsultation with you or other colleagues of yours like Dr. Ahmed, Dr. Murthy?
See, teleconsultation, as you said, for a chest pain, if I know the patient already, if I know his background illness, then when I speak to him by teleconsultation, to some extent, it would definitely help me to differentiate that this chest pain needs a hospital-based evaluation or it can be taken with some modification of his present medications. So that is one group where we can, to some extent, we can sort out when we speak directly to the patient, we see him and all that. But in a absolutely new patient, again, when you listen to his explanation, if it's a young chap and we listen to his explanations of the symptom, to some extent in small group, we can sort out maybe this is because of acidity or something. But even if there is a little doubt, it would be always to have one evaluation in the hospital rather than to neglect. Now, I think the majority of the problem that's happening in COVID is people are afraid to come to the hospital, and because of which they face more problems. And we are seeing, even we saw during the peak of COVID, that the number of cardiac patients who landed up in the hospital were less. That's not because the cardiac patients decreased, it's because they were afraid to come, and therefore the outcome of the illness, delayed presentation, increased mortality, all these are complications because the people were not willing to come to the hospital to take. So I think even if there is little bit doubt, it's better to come for one evaluation in the hospital and get it sorted out.
Absolutely. At least I would recommend to come to the emergency room with a complaint of chest pain, get evaluated by the physician in the ER, have a ECG done, at least to identify if there is anything acute, and if not, then they can follow up with you in the clinics. I would like to thank all of you for this time. One more question. There's a couple of more questions. We're so happy. Any one of you could lead the question. Dr. Ahmed, what do you can start. So frequent flying, does it affect your heart and the blood pressure? Do you suggest that businessmen who fly frequently or cabin crew, is there any rule for them to start taking aspirin to prevent heart attacks?
First of all, there is no rule to take aspirin to prevent heart attack, for sure. Second point, no, frequent flyers, yes, there is some problems with the frequent flyers. You know, there is always a trend toward dehydration, loss of mobility, and probably what we call it paces. You have to understand that the legs is supposed to uniquely push the blood back to the heart. And this depends on active muscles. And that's why sitting for a long period of time will make the blood very slow movement of the leg. There are very common reports of having thrombosis in the leg and pulmonary embolism and all things. So I actually emphasize, instead of getting aspirin, I think it is more important is to do leg exercise while flying, get adequate hydration, try to move around, and that is even more important than aspirin.
So well said. So well said, Dr. Ahmed. Well
said. Far more important than aspirin. Just leg exercise, some stalking, a lot of hydration, and try to take a short walk during long flight. I think it's more important than aspirin.
Absolutely, that is helping. That is helping. True. Dr. Murli, last question for you. How can we differentiate between atrial fibrillation and SVT if we do not have an ECG? So just by checking the pulse, I think the person who's asked this question has some insight on these high heart rates. So he says, how do you differentiate if I don't have an ECG at home? How can I differentiate whether I have AFib or SVT?
Yeah, I mean, the SVT, usually you will feel a very regular fast pulse, whereas the atrial fibrillation, the pulse will be very haphazard and irregular. If he's an expert in monitoring the pulse, he will be able to differentiate the regularity versus the irregularity.
Very well, very well. So regular pulses and high heart rate is SVT. If it's irregular, they need to rush to the hospital and come and see you. Absolutely. My last question for Dr. Sundar, Mr. Ferdinand Kidela has asked us, are all chest pains, is every chest pain related to the heart? Please clarify. Dr. Sundar, this is the last question for you, sir.
No. There's not all chest pains is related to the heart. I mean, chest has many structures. It has the skin, it has the bone, it has the foot pipe, it has the lungs. So the pain can come from any of these structures. You can have a chest pain due to a problem in the skin like herpes infections. You can have a chest pain because of the bone, what we call it as costochondritis. You can have an acidity problem which presents like a chest pain. You can have a lung infection which presents like a chest pain. So not all chest pains are due to the heart. But of all the things, the most important is the heart. So you should never think that, the whatever pain I have, it could be acidity or it could be because of some skin or bone pain. And you should not neglect it, because the outcome of neglecting a pain due to the heart is extremely bad, thinking it could be because of other reasons. So when you have a chest pain, it's better to evaluate, but it could be because of multiple reasons.
So again, we would all agree to one thing: when in doubt, shout. This would be the best slogan, rather than staying at home and delaying the treatment. We have received a lot of positive reviews to all our experts, all the three of you. Thank you very much for giving us time. I would also like to request the viewers and all those who are with us on this platform, and those who will be watching this at a later point, the numbers of our appointment numbers are on screen. You can also find it on our website. You can follow up. You can book appointments with our expert cardiologists. They are experts. They are very, very good in their field. They're extremely compassionate physicians. We are very happy and very honored to have all three of you. Dr. Ahmed Jabouri, thank you for your time today. Dr. Murli, thank you for being with us. Dr. Sundar Kumar, thank you for spending time with our viewers and giving us such an insight on heart conditions. Thank you for celebrating this World Heart Day despite being socially distant from each other. Thank you for being prime. Thank you for being primary physicians, which is heart physicians. Thank you on behalf of everyone. I would like to also thank the management, the Prime Digital team, who's done a phenomenal job. Prime Hospital, all the management. We are all here 24/7. Please. Any heart-related conditions or any other conditions, we are always here to take care of you, personalized care personally. Thank you very much. Have a good day.
Thank you.
Thank you. Thank you all. Thank you, Dr. Ahmed. Bye.
Thank you.